Hey there everybody, welcome to the next SIR models video. In this video I'm going to cover the basic reproduction number R0 of a given disease and then put this COVID-19 outbreak in an SIR models context. Let me just say up front that the reason I wanted to make this video was that I wasn't sure if you guys are hearing enough or thinking enough about COVID-19. You guys heard anything about that, It's so hard to hear anybody discuss this disease. Well, I'm here to fix that, okay? You want to hear about the disease? I will tell you about it. And I'm the only source you can trust on this, okay? So the goal of this video is, as I said, to discuss R0. And the reason I want to discuss R0 is that it's a measure of contagiousness. And if you have seen in a Washington Post article or a New York Times article or whatever, if you have seen numbers that measure contagiousness reported in such places, they're going to report R0. They're not going to be reporting the B parameter from the SIR model. So I just want to discuss this number in the context of these models and talk about what it means. What is it telling you? So the reproduction number R0, why does it exist and what does it do? So when discussing a particular disease, like say COVID-19 or the measles or whatever, it's nice to have just a single number that describes how bad the disease is. Sorry, there should be a disease right here, but whatever, how bad the disease is. And when I say bad, I mean in terms of contagiousness, not in terms of mortality. So something like Ebola, that is, of course, very bad. It's bad because if you get it, you have like a 40-50% chance of dying from it. But Ebola is not bad in terms of contagiousness. It is not a very contagious disease. So anyway, if you're trying to measure how contagious a disease is, the epidemiological literature focuses on this number R0, which is termed the reproduction number or basic reproduction number of a disease. This number is defined like this: the average number of new infecteds produced by a single infected. So the larger this number is, the more contagious, bad the disease is, the more likely that epidemics will occur. And the more likely that those epidemics will be bad in the sense that like more people get sick and it happens more quickly. So maybe your healthcare system gets overwhelmed, things like this. So just to be concrete about this, if I tell you that measles has an R0 value of 12, I'm telling you that each person who has the measles will, on average, infect 12 other people. That's terrible. And measles, by the way, 12 is usually the lower end of the estimates for R0. So the lowest value for R0 amongst SIR modelable, that's a hard word to say, the lowest R0 value amongst diseases that SIR care about is MERS. Of diseases you've heard of, maybe. I don't know if you've heard of MERS, but anyway, it was another coronavirus. The R0 value for MERS is pretty low, between 0.3 and 0.8 are the estimates. Measles is terrible. The estimates range from 12 to 18. Okay, so with MERS, each infected person on average infects less than half of another person, according to this number, 0.3, right? With measles, you can infect 18 other people. Terrible. Okay, so a big old caveat here. This R0 value is not like some intrinsic property of the disease. It's not like measles everywhere always has an R0 value of 12. So, of course, how contagious a disease is does depend on the disease itself. I mean, some diseases are more contagious than others. However, the R0 value also depends on the society that the disease exists in, or even on things like environmental factors or seasonal factors or whatever. So if a society changes its behavior in response to an outbreak, you can say lower that R0 value. So just as an example, the 2014 Ebola outbreak, this is the worst one on record in Western Africa, R0 was estimated to be between 1.5 and 2.5. which is bad. So on average, each infected person produced like 2 more infected people on that outbreak. In the U.S., though, because of basically societal behavior, the R0 value for Ebola for us is 0. So the reason Ebola was so bad in this outbreak is that the societies in which it was bad, they did not change their behavior until late in the epidemic. And their behavior was things like I think it was their burial rituals. Their burial rituals involved a lot of contact with the dead, and that's how the disease was spreading. So if that's what your burial rituals are like, then R0 is going to be higher for you. Whereas in the U.S., right, we're not handling the dead, right? I don't handle my dead father or whatever. Okay, so a punchline. Given a disease, there's no single R0 value for that disease, especially if a given society is willing to change its behavior. However, it is still like a nice little, if you just want a number to summarize contagiousness, it's nice to have that number in mind with this punchline also in mind, right? Sort of the caveat. So, R naught, where is this in the SIR models? Okay, because the models that we built have basically two parameters, B and K. So how does R naught fit into that? There are some subtleties here that I'm not going to go into, but basically this is what R naught is in terms of our models. R naught is basically just a product of B and K. So B was sort of a effective contact rate per day, and then K was like number of days you're sick. So if you multiply those, then you get sort of an average number of new infecteds produced by a single infected. So if you're going to build an SIR model, you need both B and K. Well, if nobody is reporting B, that can be a problem for you, right? However, the medical literature, epidemiologists, people like this, they try to estimate R naught, and then this K value is just like the length of the disease in an infected person. So everybody is always trying to estimate that. So both R naught and K are fairly straightforward to estimate once you have a large data set. So anyway, if you look on like PubMed or whatever, and you're interested in building an SIR model, you can usually find R naught and you can usually find K if you know how to look. Among other things, one of the reasons you might care about R naught is that if you care about trying to predict if an epidemic will occur or not, there's a nice little relationship between R naught and the initial number of susceptibles or the initial number of recovereds that lets you determine whether or not an epidemic occurs. So R naught has nice uses like that, and your homework teases this out. So if you look at, I forget which number it is, but one of the homework problems, the entire point of the problem is to discover what conditions you need on R naught so that your epidemic doesn't occur. All right, so now let's talk about COVID-19. I should say up front that I was very hesitant to talk about this disease at all in this course. The reason being that it is not well understood. The data is incomplete, I guess is the best way to put it. We just don't know yet very much about the disease. So we should have some hesitation in discussing it. In particular, my Facebook feed. I hate bringing up things like Facebook, but my Facebook feed is full of people who have no medical training yet, act as if they could now be employed by the CDC or something, right? And so we don't want to be those people, right? We don't want to start just like making grand proclamations when the data is not really in. We can say some things, however. So I want to show you what we can say and give you an idea of what you might be doing, say, 6 months from now if you work at the CDC. Anyway, so the estimates for R naught for COVID-19, there's a pretty wide range right now because, again, the data is not really in, and much of the data we have is from China, and who knows how trustworthy that data is. In our own country, right, in the U.S., as I'm sure many of you are aware, the testing has just been abysmal. It's just been a disaster. Like, not enough testing, basically. Not enough testing means data that, it's incomplete, and it's hard to estimate things like death rates or whatever. At this point, I couldn't find much information on K, so I'm searching things like PubMed. Of course, you can go to Wikipedia and try to source things from there. I'm looking at sort of the math, epidemiological literature. It's just hard to know right now. Anyway, the estimates seem to be between a week and 2 weeks. Of course, these are averages, right? So you might be infectious for 3 or 4 weeks if you have a bad case. So anyway, we also don't have good data for the death rate. It does seem to be bad relative to other viruses that can be modeled with SIR. So when I first heard of COVID-19 3 months ago or whatever, I thought, oh, so it's kind of like a slightly worse version of the flu, which turned out to be quite wrong. I was quite wrong in that. It is not a slightly worse version of the flu. If it's any version at all of the flu, which it's not, but if it's any version at all of the flu, it is a much worse version. So anyway, 2009, H1N1 swine flu, death rate of approximately 2 out of every 100,000 people. Measles kills 1 out of every 100,000 people. So diseases like that, these classic SIR modelable diseases, the death rates are not particularly high. As I'm making this video, and full disclosure, I'm making this on March 28th. So I'm trying to sort of stay ahead of the game here with video making. So who knows, maybe by the time you're watching this, the data will be different, and maybe I will send an email out or something. But anyway, based on the data we have, the death rate appears higher than 1% in the US, closer to 2%. And places like Italy, the death rate seems 9% or higher. Bad. That's very bad, right? 1% means 1 out of every 100 people. That's terrible. So, it's not perhaps so terrible in the context of other coronaviruses. So SARS and MERS had much higher death rates overall. SARS had a death rate around 9%. MERS had a death rate around 35%. Terrible. Those viruses are much less contagious than COVID-19, though, we think. At the very least, they were able to be contained much more quickly. I think MERS, only like 800 people got that worldwide. Something like that. It was low. Anyway, so just in raw numbers, very few people died from these viruses, as opposed to COVID-19, which, as I'm making this, has killed more than 2,000 people just in the U.S. Okay, other considerations when you're thinking about this disease. So in addition to things like R0, K, and a mortality rate, COVID-19 seems to be dangerous in other ways. And again, I have to reiterate this caveat, okay? We are not working for the CDC right now. So again, we're just talking about this to get an idea of how you might put this disease in an SIR context, which you guys will do in your homework. The data is very preliminary, right? So we just don't know yet. As I'm making this video, people aren't even sure how it spreads necessarily. How long does the virus live on surfaces? As of right now, people don't know things like that. That being said, based on the data we have, the hospitalization rate for COVID-19 seems to be somewhere between 12 and 20%, which is bad. Okay, that's very bad. Now, when I've read about this in articles that are trying to calm people, like on CNN.com, I read an article that said something like 80% of cases are mild and require no hospitalization, and the author meant that to be comforting. And I suppose that sounds comforting when I say it like that, but if 80% are mild and require no hospitalization, that means that 20%, I guess, requires hospitalization, which is terrible. You get this disease as a 1 in 5 chance you're going to the hospital? That's awful. Anyway, stark contrast to the flu, which typically has a hospitalization rate of 1% or lower, right? 99 out of 100 people that get the flu, it really sucks, right? You're at home vomiting for 2 days, but you're not going to the hospital. At least I never have. Furthermore, if you go to the hospital and you have COVID-19, the average length of a hospital stay seems to be in the 10-day range, perhaps longer. Whereas this data here is known, right? Data about the flu. If you have the flu and you go to the hospital for that, the average stay is more like 5 days. So once we have enough data to nail down these numbers for COVID-19, then we could use SIR models to estimate things like how many people need to be hospitalized, total number of days that people will spend in the hospital, if the healthcare system will be overrun or not, and so on. One thing, by the way, I should mention that we just don't know yet about these death rates. So a death rate, of course, is partially an intrinsic property of the disease, like some diseases are deadlier than others. But with COVID-19, it's hard to tease out, like in Italy, all these people that are dying in Italy, how many of them are dying, like, quote, from the disease? And how many of them are dying because the healthcare system is overwhelmed? Like, they would have survived, but there aren't enough ventilators. Or they would have survived, but there just weren't enough hospital beds or whatever. That's hard to tease out right now. And one of the reasons, by the way, I've heard this suggested by various politicians that I won't name, but one of the reasons why you don't just want to let the disease just like run amok amongst the population and try to get it over with is that if you do that, in the United States, the conservative estimates are like hundreds of thousands of people will die from the disease who wouldn't have otherwise died if the healthcare system were going fine. So you'd have like hundreds of thousands of people who just need a ventilator but can't get one, or need a hospital bed but can't get one because the healthcare system is overrun. So based on this data here, right, if you just let the disease run its course without any social distancing or whatever at all, then you're talking about hundreds of thousands of preventable deaths in addition to the maybe 1 million or 2 million people that die from the disease as the disease, right? They die even with a ventilator. So anyway, all of this, I hope, puts some of this in some context and maybe makes you feel better about your social distancing and your quarantine right now, right? So in the homework, what you're going to do with COVID-19 is try to model an outbreak in Kansas City and also try to estimate this R0 value. So again, the data is very preliminary. So you shouldn't take your homework or this video or whatever and suddenly act like you're qualified to work as an epidemiologist at the CDC. Okay, but this is just to get an idea of what's happening and an idea of how you might build an SIR model off of this disease in this very preliminary stage.